I'll go for it.
So thank you guys all for being here. Yasmin is one of our wonderful pediatric palliative fellows who came to us via Tripler for her residency and will be staying next year at Madigan. And we are super thrilled that she's going to be in the area and be able to just be here kind of really developing pediatric palliative care down in Tacoma as well. So super excited to have her. This is a wonderful talk, super interesting and excited for her to share with us. So thanks, Yasmin, for presenting.
Thanks, Paula. Can everyone hear me okay and see the opening slide? Okay, perfect. All right, I'm going to go ahead and get started. So thank you all so much for coming. As Paula said, I'm Yasmin Curtis, one of the Peds Palliative Care Fellows, and I thought I would choose a really lighthearted and straightforward topic for my grand rounds today, the concept of suffering. There's a lot that can be said. It's a very hard topic to encapsulate in a matter of an hour, but I will certainly do my best. Some of the topics that we'll touch on today are listed here. We'll touch on many of these in brief, some in detail, and not necessarily in this order. I can promise you will hear me say the word suffering a lot. I cannot promise that I will have answers to these big existential questions, but my hope is that we will all get to thinking a little bit more about what suffering is and what suffering means. So we'll start with some definitions. I particularly like this quote from Stanley Hauerwas. He's a theologian and ethicist, and I'll read this one aloud for you all. After trying to read all I could get my hands on concerning the meaning of suffering, I am convinced that never has there been a word used with such an uncritical assumption that everyone knows what they are talking about. So to suffer originates from Latin, the prefix sub meaning from below, followed by fair to bear. And we acquired the modern word suffer in Middle English. So using two of our preeminent English language dictionaries, the Oxford English Dictionary and Merriam-Webster. And for the English nerds out here, I'm using suffer as an intransitive verb in this case. So in these cases, suffer means in the Oxford English Dictionary to undergo or submit to pain, punishment, or death, with a byline of from a disease or ailment as a potential modifier, and in Merriam-Webster to endure death, pain, or distress, to sustain loss or damage, or to be subject to disability or handicap. So those are kind of our official formal definitions from the English language, but I was curious how some people that I know and love might define suffering in their own lives. So you might see some familiar names on here. Many of these are colleagues that work in palliative care. I had to throw in ChatGPT, as one does nowadays. And then one of the persons on here is my best friend who is not in medicine, is in fact an award-winning author. And I think something to point out from people's own personal definitions of suffering is that it truly goes beyond just pain. It goes beyond just distress. There's some kind of modifier to this emotion or sensation or mood that makes it more all-encompassing, even more distressing, that it really affects many aspects of one's being, is something that I notice from all of these definitions. So I think the ways that I approached thinking about suffering, even prior to this delve into this topic that I took, was thinking about suffering as potentially affecting many domains in our lives. I think many people think of suffering as physical or psychological, but there are potentially many ways in which one can suffer on an existential level, on a social level. And so I think this is kind of the way I had framed what suffering was like in my head. And ChatGPT also supplied me with a lengthier definition that I think elucidated well the way that I thought about and approached suffering prior to delving into this research a little bit more. And I will read this one out for you all as well. Suffering can be understood as the experience of pain, distress, or hardship, whether physical, emotional, or psychological. It encompasses various forms of anguish, discomfort, and adversity that individuals endure in their lives. Suffering can arise from a range of sources, including physical illness, emotional trauma, loss, conflict, or unfulfilled desires. It is a subjective and deeply personal experience that can profoundly affect a person's well-being and overall quality of life. So now that we've talked a little bit about what suffering might mean, why does this sort of topic matter? I think that might seem a facetious question on the surface because the entire intent of medicine, in theory, is to alleviate suffering. But I think the ways in which we talk about suffering, particularly in the patient population that many of us see in palliative care and in bioethics, is to think really critically about the way that we're using and applying this word when it relates to patient care. So I'll share a little bit of the work of Dr. Erica Salter. So she is a healthcare ethicist in St. Louis, and she posits that some of the way that suffering is used in the modern day is almost as an analog to futility. And she makes a couple of assertions to that point. She references a content analysis from the 2000s that was completed, and it reviewed the use of the term suffering in over 600 occurrences of that term in pediatric ethics literature over the past 10 years. And that in those cases, 52% of the time, the term suffering was used as part of some specific medical decision for the patients that presented themselves in these papers. And claims of suffering in these patients were 3 times as likely to support a life-ending or life-extending decision. However, only about a quarter of the time was any characterization of what the person who attested to suffering meant by the word suffering, whether they were referencing physical symptoms, whether they were referencing some kind of psychological or existential distress, or both. And the author makes the assertion that we potentially use suffering, whether consciously or unconsciously, to insert value judgments about quality of life, and therefore these things impact the way we make decisions. A potential example of this is the Groningen Protocol in the Netherlands. So this is a set of guidelines established in the Netherlands that allow for active euthanasia of an infant under the age of 1 who is otherwise not terminally ill and would be potentially expected to survive for some time with maximum life-sustaining therapies. And there are a number of requirements, but I've pulled out 2 here, which include a hopeless and unbearable suffering, and the diagnosis, prognosis, and presence of unbearable suffering must be confirmed by at least 1 physician. So I think it's quite clear, probably to anybody reading this, that the ways that we talk about suffering in such a patient have very clear impacts on the livelihood of these patients. In fact, a 2009 study that looked at patients who had, quote, poor prognoses in Dutch NICUs and had to have decision-making around end of life, whether that ended up being via this protocol or via withholding or withdrawing LST. In 92% of those cases, those decisions were made not on present suffering of the infant, but rather predictions of future suffering for the infant. So now we're thinking about the implications of how we talk about suffering that has theoretically not even occurred yet, that we're going to predict might happen in the future. And another thing that the author posits here is this illusion of suffering, and the illusion here being the thinking that suffering is an easily understood concept that is clearly translatable across different people. And I think many of us know that that is certainly not the case. She kind of makes 3 big points: that suffering is not an easily identifiable or objective entity, and that healthcare providers and caregivers alike may independently judge the level of suffering that a patient is undergoing as too costly to justify the benefits of further treatment for that patient. And she asserts that we use this almost in a similar vein that we might use futility for these patients, and the ways that we might say that the benefit that a patient might gain from treatment is not significantly outweighed by the harm, or is significantly outweighed by the harm that this patient might endure by undergoing the treatment, and therefore it is potentially futile to offer or do this treatment. And then thirdly, she suggests that sometimes we use, sorry, I'm also recovering from a cold if my voice gets a little funny, but she suggests that suffering may also be used as a term to actually describe quality of life and what seems like a bad quality of life. But this may in fact obscure the specific experiences that help us understand what one means by a bad quality of life. And if we could elucidate those things further, then perhaps we would identify aspects of a bad quality of life that could be modified. And then most importantly, and a thought that I ruminate on a lot, and was one of the things that drove me to look into this topic further, was whether claims of suffering in a patient tell us more about the speaker who is asserting this than the patient themselves. For example, like as a thought exercise, I think about the patient who is intubated, sedated, and not arousable even to minimal stimuli, making assertions about patient suffering in such a patient who we cannot clearly ascertain to be in any physical pain. When we make claims about suffering in such a patient, is it really that the speaker is saying this is not a quality of life I would want for myself, or even in fact, am I suffering by providing care that I feel moral distress in providing? And I think this is a really big, important question without any clear answers, but I think it's something important to always think about, is whose suffering and distress are we actually treating in these moments? So we're going to pivot away from medicine a little bit now that I've left you all with that. I think in exploring suffering and the way that we've kind of come to our modern understanding of suffering, it behooves us to look to the past a little bit and think about the ways that our cultural and social approaches to suffering have changed over the centuries. And we'll talk a little bit about this concept posited by this philosopher and anthropologist of positive and negative models of suffering. So in this work here, he proposed these two almost diametrically opposed models, and he asserts that with the Enlightenment, there was kind of a shift broadly on a social level, at least in the West. This is focused on the West, from a more positive model of suffering to a more negative model of suffering in an occurrence that he called the rationalization of suffering. And we will talk about some of those models here shortly. So what he defines as a positive model of suffering is the thinking that suffering is purposeful in some way. So suffering plays some kind of redemptive role in human life, that it helps us gain something new. It gives us new perspective. We are otherwise enlightened as a result of undergoing suffering, and it is something to endure to achieve something better. And probably unsurprisingly, many positive models of suffering lean on the theological side, though there are some secular models of suffering that gear towards the positive as well. And then on the other hand, a more negative model of suffering asserts that suffering is purposeless, that there's nothing good to gain from an experience that's dominated by pain. And in fact, suffering is something that we should eliminate or swiftly anesthetize. These lean on the secular, but there are also some theological models that assert that suffering is purposeless as well. And the author also asserts that culture kind of helps us determine which side of the pendulum that we land on a little bit. The culture in which we're raised in presents us almost with these standards of reality that we then apply all of our experiences to. And this may help us lean one way or the other, but then also asserts that broadly in the West, on a social level, we have gradually shifted from a positive to a negative model of suffering. And we've shifted from thinking of suffering almost on a philosophical or spiritual level, something for reflection, to thinking more about suffering in a biological means or behavioral political means as something that we should intervene upon and eliminate. We'll start with a few positive models of suffering that the author touches upon in the article. Some he expounds upon in detail, some he references briefly that I expounded upon, and some I found in other sources. So Christianity, I think, is probably not a surprise to anyone. And I imagine that many people here, whether they have wanted to or not, have been exposed to Christian theology. So I will not belabor the point here, but to try to boil it down into one slide, in Christian theology, suffering, and important to note that in the positive model, suffering is not inherently a moral good, but it can cause something better at the end of suffering once one has endured through it. So in Christian theology, suffering is a manifestation of evil in the world, but by that same token, suffering is part of God's redemptive plan for people on earth to become more like Jesus Christ. One must be willing to go through suffering for spiritual advancement and enlightenment. a non-Western example of a religion that has, as the author asserts, a positive model of suffering is Buddhism. And I certainly apologize for any inaccuracies about Buddhism here and welcome any corrections. But as best as I could understand from my research, part of the central tenets of Buddhism surround these four noble truths who are recognized by those who wish to stop suffering. And the term in Sanskrit, dukkha, is not always translated directly as suffering, and sometimes is translated instead as discontent or misery. But for the purposes of the presentation, we will use the term suffering. And some of the tenets say that, one, that suffering exists and that life is suffering, and until one recognizes this, you will continue to suffer, and that the cause of suffering in this case is the illusion of permanence in a world that is not permanent. That there is a way to end this suffering in pursuit of true enlightenment, and the way that one can achieve this enlightenment is to follow the Noble Eightfold Path. And so these are the 8 boxes that I have here at the bottom. And my thinking, because the author did not expound upon Buddhism other than to reference it as a positive model of suffering, my suspicion is that his assertion here is that suffering then drives one to be more wise, to think more critically about the way that they interact with people and with the world, and to have greater mental discipline. So it drives one to better themselves, essentially, in the way that they interact with the world to help escape suffering. We'll talk about a couple secular positive models of suffering. So Freud also needs no introduction, but to boil it down, in Freudian psychoanalysis, one big theme that comes up is that sometimes one must be willing to undergo these sort of painful ordeals of awakening to emerge into fuller health. And this is often via psychoanalysis, and that the assertion is made that any acute emotional distress or suffering often signals that the psyche is moving towards this fuller consciousness, and gives the example that, you are experiencing the fullness of this grief right now because before you were tamping it down with this kind of self-numbing depression. And once you fully experience the pain of this grief, you will emerge into a fuller consciousness. And I kind of liken this to this thought of pain as weakness leaving the body. And then the romantic model of suffering. So the romantic movement was an intellectual and psychological movement, or philosophical movement rather, that was sort of an answer to the Enlightenment, focused a lot on nature, and a rejection of industrialization and rationalization. And along with that, they posited that nature has some creative and some destructive elements. So by destructing elements being part of our reality, they have to have some kind of significance to our existence because they exist. And then secondarily, that the capacity to suffer makes us compassionate, that we are more likely to want to alleviate suffering in others because we know what it feels like to suffer. And that, in fact, those who don't suffer actually have an incomplete grasp of life, that suffering is what makes us human and is a humanizing force. And then lastly, thinking about suffering almost from a Darwinian perspective, is there something about suffering that gives us a biological or evolutionary advantage, or even a sociological advantage in the ways that we interact within our societies? And one thing that a separate source posited is that suffering potentially helps us recognize experiences that are destructive or harmful and helps us find solutions to those things. So for example, is this some kind of warning of possible harm that we need to be paying attention to? Is the suffering we're enduring pushing us to develop new discoveries, e.g. painkillers, for example, that could make us more functional within society, or make us otherwise more biologically fit? Does it help us express ourselves and then use those things to communicate about our experiences to other people, for example? So those are kind of a brief overview of some models of suffering that make the assertion that suffering is purposeful for some reason. And now we'll talk about some negative models of suffering, both from the secular and theological perspective. So the Enlightenment, we've alluded to previously, but this was a philosophical movement in and of itself. In the 18th and 19th century, that kind of focused, or rather the 17th and 18th century, that was focused a lot on industrialization, capitalism, rationalization, scientific thought. And one of the primary aims was to decrease the authority of the church. And this was kind of the initial thinking of the separation of church and state. And something important to decrease the authority of the church was to take away the people's need for an answer from the church to suffering. And so instead, they turned to suffering as the outcome of chaos in the world or the outcome of human error. In fact, the author makes some strong assertions about the way modern psychiatry has come to be. So I will say these are the opinions of the author and not my own, but he asserts that for psychiatry to get to the place that we know of it today, to gain equal footing with other medical disciplines, because prior to that, there was a lot of predominance of psychoanalysis. They had to make the assertion that all mental phenomena that we experience can also be explained biologically, and thus the way that we treat it should follow the same principles of the way we treat other physical ailments, that we should think about using medication and pharmacology to treat some of these things. And that as a result of that, there was a not complete but gradual devaluation of some of the more spiritual or existential causes of distress that one might experience, and makes a strong assertion that a capitalist economy, kind of following the Enlightenment, required an anesthetized workforce, so to speak, aligning with the rise of psychiatric pharmacology. Scientology is another religion I did not know much about prior to this presentation, and invite any corrections, but from what I could learn, in Scientology, it is believed that the mind has two parts. There's kind of the analytical, higher thinking mind that can think about things on an abstract level, and then the reactive mind, kind of like the emotional hindbrain, that takes over in times of stress and presents these negative images and feelings that are present in your unconscious. And these are the source of human suffering, these quote engrams. And the one of the aims of Scientology and its classes is to revisit these negative thoughts and feelings and memories, and to erase the effects of them so that one can become enlightened, so to speak. The term is clear, that they're free of pain, free of negative emotions, and the basic goodness of them can come to the fore. That suffering in this case is something that should be completely eliminated, if at all possible. This, I had to put in a reference to Everything Everywhere All at Once. If you have seen it, you will understand the bagel. But an existential nihilist take, so a non-theological, secular take on suffering as purposeless, and a nihilistic view asserts that, at least an existential nihilistic view asserts that nothing has meaning in life, and so therefore suffering also does not have meaning in life, and that suffering is just another way in which we try to create meaning in a meaningless existence, essentially. And then this is kind of the answer to the almost Darwinian or evolutionary model on the positive side, is the non-adaptive side, and that there is some evidence that the things we experience clearly do not confer any kind of biological or societal benefit to us. Some examples might be chronic pain and the absence of tissue damage that makes us less physically capable and able to carry out our respective roles and duties, some mental illness that we might experience that makes us less able to function on a social level and continue the advancement of our people, that these demonstrate some examples in which this does not help us advance the human race. So we've talked a little bit about some differing models of how one might think about suffering as either purposeful or purposeless, and a little bit about the way in which over the 18th, 19th, 20th century, we've moved from a more theological, positive model of suffering, at least in the West, to a more negative, biological, political focus on suffering. And now we'll take a little bit of a dive through the ways suffering has been discussed in the medical literature and throughout medicine. So I'm sure Dr. Eric Cassell needs no introduction. For many of you all, he is often thought of as the intellectual father of palliative care. And he had a seminal work and many seminal works on the concept of suffering and medicine. and started this work in the 80s. And prior to this, a lot of the literature around suffering was focused on suffering out of physical pain or some negation of a good, but not a lot of elaboration on suffering and what people who are suffering are experiencing and patients who are suffering are experiencing. So there are a couple key features of Dr. Eric Cassell's theory on suffering that we'll expound upon here. One was this rejection of Descartes' Enlightenment philosophy of Cartesian dualism or mind-body dualism, which was really the separation of the mind and the body. So the mind is in the non-corporeal spiritual space, and the body is relegated to the physical and scientific space. And by separating these two things, this was one means in which Enlightenment philosophers might try to escape some of the dominion of the church by saying, no, my physical body is in another realm. My mind can be the dominion of the church, but not my physical body. And this is subject to science and to medicine. And Dr. Cassell made a refutation of that, saying that it is not just bodies that suffer, but it is persons that suffer. Persons is almost analogous to the mind in this case, but a lot of his model focuses on this concept of personhood, that we have bodies, but it is people that suffer, and that suffering can have a variety of causes beyond just the physical. And thinking about that in our patients is critically important to ensure that we treat them appropriately. Another key feature of Dr. Cassell's model is that suffering has some kind of temporal element, that there is some threat to the destruction of a person, that there is some potential disintegration even of the personhood of the patient. And he gives this example when talking about physical pain, that there are many potential modifiers of pain that cause pain then to become suffering. For example, worrying that the pain will not be able to be controlled, if the pain is unrelenting, if the source is unknown, if the pain is quite chronic, and gives the example of if I have pain in my leg from a muscle cramp, for example, it might not feel as bad to me, but if I then learn that the pain in my leg is from osteosarcoma, this could modify the pain and increase the severity of the pain now that I know that the source is something significant. And now in this case, the pain is now a threat to my existence, because what the pain means is something potentially dire, and this could affect my integrity, in fact, as a person. Another key feature is his assertion that suffering is always inherently subjective, that suffering is experienced by persons, and that the meaning of this experience is going to vary from person to person, that each person can experience suffering completely differently, even with the same illness. The only way we could understand what a person is going through is to know the whole person, but this is also impossible to know because people are also transient concepts, because we are always growing and changing. Our circumstances are constantly changing. But to try to understand, there are three key things that we should try to elucidate from the patients. One is the facts, so kind of the medical facts of the case. Two being the patient's own personal values. And then three, what he calls the quote aesthetic knowledge, which I think the quickest way to translate this would be, what are the context clues that you're picking up about the patient? When you see them, are their clothes clean? Do they tend to have someone with them? Who is their caregiver? What are the things the patient isn't sharing with you that you are picking up about them or their environment or their situation just by observing them? And he also talks about this topology of a person and says that these are all the aspects of personhood that are either modified by suffering or modify the way in which we experience suffering. Oops, went one slide too far. For a definition for some of these concepts in the bottom right, the transcendental dimension he means as the spirit, and then secret life he means as kind of our secret hopes, desires, and wishes that we don't share with other people. But he says these things can be irrevocably modified by suffering, or can significantly modify the way in which we experience suffering, depending on the day, the moment even. The way that Dr. Cassell suggests that we ameliorate suffering is in threefold. One is support from family members, medical teams, or even groups who have gone through something similar to the patient that we are treating. Second is to try, if we can, to help the patient assign some kind of meaning to the condition that they're going through, which may potentially make it feel less destructive, that instead the suffering becomes part of their personhood if they can assign some sort of meaning to it. And then thirdly, transcendence, and taking the person out of the experience of pain, helping them understand them and their existence almost on a spiritual level, though it's not inherently a spiritual concept. He also talks about patriotic acts as a way in which a person can gain some kind of transcendence. And that by doing these three things, we can potentially help our patients alleviate the suffering that they are experiencing. Now, there have been many criticisms of Dr. Cassell's model over the decades since he initially published his seminal work in the 80s. So we're now jumping way ahead to the late 2010s and 2020s. Dr. Tyler Tate is a pediatric palliative care physician and bioethicist at OHSU and is actually a graduate of the Seattle Children's Bioethics Fellowship as well. And for me, he helpfully collated many arguments against Cassell's model and then also posited his own model. So I'll be referencing his work frequently from here on out. And he says that criticisms of Cassell's model kind of fall under two headers. And one is a criticism of the way in which Dr. Cassell talks about the subjective suffering experience. And then two is a dismissal of objective suffering. I didn't say it explicitly, but one underside of Dr. Cassell's model in which he says suffering is inherently always subjective is then that people who cannot articulate or rationalize or intellectualize their experience therefore cannot suffer, and makes the assertion, for example, that newborns cannot suffer because they cannot articulate their experience. They can experience pain, but they cannot suffer. And there are some criticisms of these theories. So under the subjectivity of suffering that Dr. Cassell was talking about, Dr. Tate and other bioethicists and philosophers have suggested that when Dr. Cassell is talking about suffering as this kind of threat to the intactness of a person, that in fact, some can suffer even if they know their intactness is not likely to be threatened. For example, someone home with the flu may be suffering from the physical complaints of the flu, knowing that it is statistically very likely that they are going to recover from that experience. And then secondly, Dr. Cassell does also assert that bodies do not suffer, people suffer, and that people instead just have a body, but in some way, by doing that, he's playing into that mind-body dualism that he was trying to refute. And then thirdly, transforming suffering into meaning can invite bad people to manipulate the suffering experience for their own gain. I think Karl Marx said, the statement that religion is sedating the proletariat to their own pitiable existence. And that is a similar line of thinking in which persons can manipulate the way in which patients create meaning from their suffering in negative ways. And then in the header of this dismissal of objective suffering, Dr. Tate makes the argument that those who aren't able to have insight into their experience can still suffer, and gives the example of a child who is being sexually abused. If that abuse has been normalized by the perpetrator, perhaps that child may not be able to say or feel or understand that they are suffering, but many of us externally might still argue that that child is suffering. He also asserts that for many world religions, suffering is best understood as in reference to some kind of external force to the person or to the patient that helps them understand or rationalize their suffering. So there is some kind of external component to the way that we think about suffering. And then argued that infants and individuals who have brain injuries can suffer because they Dr. Cassell asserted they couldn't suffer because they couldn't attach meaning, and Dr. Tate asserts that they potentially can, and will explore some ways in which we create models that include such patients. So Dr. Tate puts forth his own model of suffering in the subjective sense, and we'll talk a little bit more about objective suffering and someone who can't articulate their experience a little bit later. But for those who can, he shares that the language used by Dr. Cassell is potentially needlessly violent, this thinking of a threat to personhood, and asserts that many people may in fact describe suffering as a loss, that they are losing some part of their identity or their selfhood. And along with that, they have a negative experience and negative feelings associated with that loss. And some of the domains in which there may be loss is in the relationships that they have, that part of ourselves are determined by the relationships that we have with other people. I, for example, am a mother, I am a daughter, I am a niece, I am a wife, and the way that those relationships are impacted by the suffering experience can cause that loss of selfhood. Similarly, the roles that we fulfill, for example, physician, firefighter, as in this photo here, can also be irrevocably modified by whatever we're going through that is causing a suffering experience. And then thirdly, our narrative, our own personal narrative, the story of our life, so to speak, that is going to be also irrevocably modified by an illness experience. And this can create some loss if there are things that we hoped or dreamed for our lives and our future. Or is this physical illness now implicating something that happened in our past? So along with this loss of selfhood, he asserts there needs to be this suffering affect. So this negative experience associated with this loss of selfhood. And I quite liked this quote from his work, that many patients who suffer seem to have sorrow etched down into their bones, that suffering is this mood. It is the window in which every experience is filtered through, any thought, any decision. The feeling's negative, it's intense, it's dark, and it's hopeless. And this kind of negative affect, along with this loss of selfhood, is what presents us Dr. Tate's subjective model of suffering. Now we'll talk about even sadder topic, suffering in children. And I would ask that those who do not do pediatrics not check out entirely, as I think many of the implications of this discussion can also apply to our adult patients who are otherwise unable to speak for themselves or articulate their experience if they are sedated, have brain injury, have severe dementia, for example. But I think when we start thinking about objective suffering, when we're trying to assign suffering to someone who cannot articulate that they are suffering, it behooves us to be even more critical and think even more in depth about what we mean and what we're talking about for these patients who can't speak for themselves. And so questions that come to my mind are how do we talk about suffering in children who cannot speak for themselves? And I give several examples of such children, but also any patient of any age who cannot speak for themselves. And how does the way that we talk about suffering in these patients impact the medical decisions that we parents, and I'd also say caregivers, surrogate decision makers, healthcare providers make for these patients? Dr. Tate boils this down into kind of three broad, bigger questions under the headers of metaphysics, epistemology, and ethics. Told you guys we'd be getting deep here. So, in the metaphysics header, what is suffering for someone who cannot communicate about their experience? Secondarily, how can we know if someone who can't communicate is suffering, or how can we know if someone who can't communicate will suffer in the future? And then thirdly, how do we respond to the suffering of someone who cannot communicate? In pediatrics, he asserts that there are kind of two almost diametrically opposed poles of the way that we think about and apply suffering to our decision making. And he asserts that on the one side, we have leaning more towards Dr. Cassell's model, which asserts that in order to suffer, a person has to be aware of the past and the future and be able to assign meaning to that experience. That is why animals can suffer, but very young infants cannot. They can have pain, even terrible pain, but not suffer. And the author asserts that more in line with this thinking is why sometimes we give parents of patients with profound disability, whether physical or cognitive, a great amount of decision-making authority over the lives of their children because of some inherent thought that we do not know really how much or whether some of these children can suffer. On the other hand, we have the concern that a child could really be suffering, in fact, and that they could not articulate the fact that they're suffering. And the thought of such an occurrence is so distressing that, in fact, death is preferable for these children, so they do not have to undergo this suffering experience. And I think kind of the logical extension of this thinking is where one arrives at the Dutch Groningen protocol that we talked a little bit about in the beginning, and extending even further. This may be a little bit more of a logical leap, but thinking about death with dignity And I imagine for many patients, there's a worry that they will suffer and not be able to articulate the suffering they're experiencing, and that death might, in fact, be preferable to that experience, even if they were going to eventually pass from their disease. So there are a couple of models that try to take into account the experience of children in particular, and try to create a model of suffering or a theory of suffering that encompasses the experiences that young infants and children and those who can't speak for themselves might have. So we'll present a couple here. First, we'll talk about the spectrum of feeling. Dr. Mayerfield, who is a UW political theorist, talks about suffering as being on a spectrum, suffering on one end and happiness on the other end. And in an attempt to try to include as many experiences of suffering as possible, the language about what suffering is simplified to an extent to, for example, being a disagreeable overall feeling at any particular moment. A criticism of this model suggests that, for example, a base example, if I stub my toe right now, I might argue that's a disagreeable overall feeling. Am I now suffering because I've stubbed my toe? And a criticism, therefore, is by simplifying the language, it is possible that we diminish the meaning of suffering and what the suffering experience truly is. The desire view from Dr. Michael Brady, a British philosopher, asserts that suffering is the desire for some negative or unpleasant experience that the person, the patient, the sufferer is currently undergoing to stop. I think it's not a big logical leap for many of us to assume that an infant who is in pain for one reason or another may not want to be in pain anymore. But it does become a slippery slope, is a criticism, when we start to think too much about how accurately we can identify the desires of an infant, for example. And secondarily, there may be experiences that are painful, but are inherently necessary for flourishing. For example, teething pain. An infant might be crying because they have teething pain. They may, in fact, want that pain to stop, but that pain is a necessary part of their development. Then are they suffering from that teething pain? Big philosophical questions here. And then relational suffering is another way of thinking about it. And the first author on this paper was Dr. Georgina Campaglia, a UW bioethicist, but Dr. Jennifer Kett, one of our very own in palliative care, was also an author on this paper and talked about suffering in children as relational. So these children do not exist in isolation. They are understood by the people that are around them. And so is their suffering, that we cannot think about the suffering of a child without thinking about the way the suffering impacts those around them and is interpreted by those who are around them. And in fact, we also need to ensure we're including thinking about the suffering in those people around the patient. And therefore, instead of asking, is the patient suffering, should we be asking, is there suffering here? Should we be taking a step back and looking more broadly at the suffering experience in this community, in fact? And then Dr. Tyler Tate's own model, and he asserts that it is really hard to make one cohesive model of suffering that includes both the subjective and objective experience of suffering. So this is his separate objective model of suffering in someone who cannot articulate it, in which we are determining whether they're suffering or not. And he titles his The Absence of Flourishing. So that suffering is on one end of a spectrum and flourishing is on another. And that suffering in children is really a set of absences, an absence of love, an absence of warmth, an absence of freedom from pain. And these are the things needed to flourish. But that flourishing is going to be very different from patient to patient and child to child. And that what is flourishing for one is not necessarily flourishing for another. And that flourishing is in and of itself an individual experience, and makes the logical extension in his article that, for example, a well-publicized case was the case of Jahi McMath, who was unfortunately brain dead, and whose parents wanted to continue life-sustaining measures for her. He makes the assertion that perhaps, although it was very morally distressing for many of us to treat Jahi, that perhaps she was not suffering because she was surrounded by love and warmth, and as best as one could tell, potentially she was not in pain. So it is perhaps theoretically possible that she was flourishing. And he says, importantly, that suffering, and these patients in particular, requires a village. It requires all the people that surround them in their personal lives and all of the healthcare providers who are caring for them to help prevent suffering in these patients. So we've talked a little bit about suffering in medicine and the way that suffering is discussed and described in the medical literature. How do we then measure suffering or assess suffering? And what do we do to respond to suffering when we do see it? There are a couple of instruments that are out there that make an attempt to measure suffering, and I've listed a handful here. There's a group here that assessed several of these instruments, and the group's primary aim is to try to find the very best medical assessment instruments needed in any particular case. And so they evaluated all of these instruments according to their own metrics, and they determined that the suffering pictogram was the most robust of the options that are currently present. And these are worldwide. So the suffering pictogram was developed in Malaysia. This did demonstrate some reliability and validity. It was originally written in English, and it was studied on inpatient palliative care patients, primarily those with cancer. And many of these scales that attempt to measure suffering use a Likert scale for the patients to measure the relative severity of their experience. And this suffering pictogram comprises 1 sensory, 4 emotional, 2 cognitive, and 1 spiritual scale on it. This model here is from the UW Department of Family Medicine. This is a comprehensive clinical model of suffering developed by this group, and it comprises kind of 4 axes of suffering and then 8 relative domains of suffering that align with one particular, and 2 of each align with one particular axis. And along with this, they have kind of a list of potential threats, so to speak, in the language of Dr. Cassell, to the personhood that might align with some of these domains, and then also some questions one might ask that get at some of these domains that they title a review of suffering, analogous to our review of symptoms. And in the center here is 5 common patient experiences of suffering, and their hope is that this could be potentially a guide for clinicians anywhere, but particularly in the outpatient primary care sphere, to guide the way they talk about suffering with their patients, even in a primary care environment. So this is what I was alluding to here, some of the like threats or losses that could be associated with various domains of suffering that they assert in this paper. And then secondarily, some questions that one might be able to ask patients in a visit to try to get at some of these domains of suffering. So we have arrived at the end. Now that we've learned a lot about suffering, what do we do in the face of it? How do we respond to suffering when we are worried that it is present or a patient asserts that they are suffering? This may be a little anticlimactic, and that is mostly because there's no simple answer to the way that we respond to suffering. It is much of what we learn intuitively, certainly in palliative care, but there are a couple of different thoughts, one on the end of responding to subjective suffering from a patient who can articulate what they feel that they are experiencing. And these are pulled from Dr. Tyler Tate's work as well. And he makes 3 recommendations for how we respond to subjective suffering. So 1 being that we seek to understand the patient's lived experience. 2, that we inquire into the patient's experiences, paying attention to the potential losses that may be present. And in those 3 domains that he discussed in his model, being loss of relationship, loss of roles, loss of narrative, and then really just actively listening, leaning in, having intention about it, showing your presence, listening and responding to those emotional cues, and really just sitting with them in that experience. I think, as many of us know, in palliative care, there is often not much that we can do to actually alleviate the emotions or the suffering that patients are experiencing. But by coming down and letting them know that they are not alone and we are here and we are listening to them is one of the ways that we can try to alleviate some of the distress that our patients may be experiencing. And when we think about objective suffering and the ways that we respond to objective suffering, this is pulled from Dr. Erica Salter's work, who we talked about at the very beginning, where she made the assertion that sometimes we talk about suffering as the new futility. And some of her recommendations include trying to avoid giving suffering more moral weight than other concepts that we use in medicine. For example, concepts like harms or benefits. And I really like the second point, is really trying to assume a posture of humility about what the patient is experiencing, because the reality is that nobody can know what the patient is experiencing other than the patient. And we are always going to be making some kind of value judgment about what the patient is experiencing, whether we want to or not. So just trying as best as we can to assume this posture of humility. And she says, if people are asserting that a patient who cannot speak for themselves is suffering, whether that be the healthcare team or their surrogate decision makers, being really specific, asking what they mean, what are they seeing, what are they worried about, what do they see the patient experiencing, taking those concerns very seriously, addressing any physical concerns as best you can, and then responding to those more emotional or existential concerns by really leaning in. It is easy to get uncomfortable when people talk about this emotional or existential suffering. And in the face of that, it is easy to want to take a step back to protect ourselves. But by doing so, we miss an opportunity to try to help alleviate some of the suffering that may be present. And then thirdly, she says, definitely acknowledge the suffering that the surrogate decision makers or the healthcare team is experiencing too. Because I think we all know that many of our colleagues and many of these parents and caregivers and next of kin are suffering too, as they watch their loved ones go through these experiences. So acknowledging the presence of the suffering, providing avenues when and where we can for them to express the suffering that they're experiencing, whether that be through debriefs or through some parent support groups, for example. And I will leave you all with this quote. This is from a very dear friend of mine who's currently a pediatric critical care fellow at CS Mott in Michigan, who has unfortunately had many personal losses in her own life in the last few years, and wrote what I thought was a very beautiful, her own beautiful personal definition of suffering. And here are my references. And I think I'm frozen a little bit, but my next slide just asks if there are any questions. Here we go. If anyone's interested in further reading, this is where I was hoping to get to. Dr. Eric Cassell published a book as well, based on some of his thoughts about suffering. And then this anthology here, Suffering and Bioethics, I think talks about a lot of things that I talked about, and probably much more eloquently within this book. So that's another one that I would recommend. And I'd be happy to take any questions or thoughts. And if no one has questions, I have a question for you all. There is not a good place to put this slide, but another food for thought is whether pain or suffering are always inherently bad if some seek these experiences out. I see Jen's hand raised.
Well, I have a comment rather than an answer to your question, but I hope that's okay. That was a lovely trip through just suffering in sort of all its forms and descriptions, and thank you for raising this, and also thank you for including both the Salter paper and then Aaron Whiteman and Gina Campiglia's work on this. I think is really incredible. I just want to highlight something that you said early on that comes from Salter and also Aaron and Gina, which is that suffering tells us something about the patient, and also probably a lot about the person who's making the assertion that they're suffering. And it's one of the things as a palliative care doc and also as an ethicist that I stay alert to when a team is making claims about suffering, especially claims that are sort of very intense and kind of out of scope of the way that we usually kind of talk about patients. A lot of times that's a sort of red flag for, yes, concern about the patient, but also that the team has maybe decided that this patient isn't worth helping, or that there's something sort of deeper and more meaningful going on that deserves unpacking. I think Salter's questions are a good start, but when I've asked people before, tell me more about what you mean by suffering, they often kind of want to punch you in the snoot. And so it's, I think, a good starting place. And I think she's right that we want to unpack what people are really worried about and really meaning when they're saying, but the patient is suffering, but the patient is suffering. And meanwhile, they're a baby in the NICU on a ventilator, like every other baby in the NICU on a ventilator, who aren't getting any kind of pain or sedation, pain medication or sedation medication. And so why are we worried about this baby in particular, and what exactly are we worried about? And let's kind of unpack it together. So just want to say thank you for raising that. I think it's a really important point.
Thank you so much, Jen. Sorry for my frog voice. I have Dr. Erin Whiteman's hand raised as well. Thank you so much for being here.
Yeah, hi Yasmin. That was really nice. I guess in response to your question, I always like, to go to a different secular description of suffering. Viktor Frankl's description of suffering as suffering in some ways can cease to be suffering when it is attached to meaning. And really it highlights the role that we can play in supporting our colleagues and patients and families in highlighting and really recognizing meaning in experience, in addition to the suffering aspects of it. I think to add to Jen's point, one other very practical reference, at least in terms of approaching and thinking about patients who can't communicate with themselves. Dory Bogetz wrote a paper a couple of years ago in Acta Pediatrica that offers some practical steps. But I if it's all right, I have a question for you that goes back to the very beginning of your talk, where you mentioned, that addressing suffering, mitigating suffering is a primary duty for clinicians. Particularly palliative care clinicians, but all of us really. Mm-hmm. And in that sense, and Erica Salter writes about this too, suffering has a lot of power as a term. It demands action. We have to do something about suffering. And especially in light of the challenges in defining it and describing it. For me, that raises concerns about power, because whoever makes a claim about suffering has a way of demanding action from us. Sometimes action to do things like mitigate pain, but sometimes action to do things at the extreme, as you suggested with the Groningen protocol. I wonder what your experience has been, or what you think about the role of power dynamics and power in terms of thinking about suffering, especially if it's not the patient themselves who is either able to or is making the claim about suffering.
Yeah, thank you, Dr. Whiteman. That's such an important comment, and something that I think about a lot, and will go ahead and say I don't have an easy answer to that question, other than that it's something that I ruminate on a lot. And in fact, one of the anecdotes shared by one of my co-fellows that drove me to look into this topic a little bit more was, I'm going to paraphrase quite a bit, as I did not care for this patient and many of the details escape me, but there's a patient who was very critically ill, whose legal next of kin were in another country and unable to be at the bedside. There was great moral distress by the team about the care that was being provided to this patient, and felt that it was inappropriate to continue, and felt very strongly that the patient was suffering, at least in the physical sense, and in some ways demanded that the family bear witness to this, and in some ways almost forced them to look at what the patient looked at the bedside, even against their will to an extent, and would assert to them that the patient was suffering. And the family response to that was, where we are from, the family had emigrated from another country. We have lived through active war. That was suffering. And this experience, you trying to keep my loved one alive, is not suffering. But kind of in response to that, there was a notable shift in the way the medical team interacted with and engaged with the family, because of their concerns about the way this patient was being treated. So I don't say that I don't say that to say that I have an answer in a situation like that, but I think you're exactly right in that in healthcare, we hold so many keys and so much power because of the knowledge that we have of these medical situations. And it can lead us, whether consciously or unconsciously, to try to manipulate these experiences and the way that we talk to families to try to get the response that we want from them. I think about it a lot when we talk about code discussions, even with families. And I think the best advice that I have heard and that I try to take to heart is anytime I'm having a code discussion is to try to, for example, and I heard this from Dr. Josie Amory, who is fantastic, to try to remove my own emotional attachment to the outcome of that discussion. And that is something that I try to share with people too when they're asking my advice on how to approach some of these discussions, is as best as you can, and that's not a simple thing to do by any means for anyone in healthcare, even us in palliative care or in bioethics, but as best as one can, trying to remove your attachment to a certain outcome for some of these discussions that we have with our family members. I have no idea if that answered your question, but I love thinking about this stuff. Any other questions or thoughts? Thank you all so much for coming. I really appreciate everyone's time. And if you have other thoughts, things that I should have included or taken out, please let me know. I would love to hear those things. Otherwise, everyone have a wonderful morning.